So I'd like to introduce now our keynote speaker, Dr. Joelle Robertson-Preidler. She is an assistant professor at the Houston University of Texas Health Sciences Center, McGovern Center for Humanities and Ethics. She received a PhD in biomedical ethics from the University of Zurich in Switzerland. And she also completed her clinical ethics fellowship and worked as an assistant professor at the Baylor College of Medicine Center for Medical Ethics and Health Policy in Texas. Her research and teaching interests focus on equitable communication and decision-making for patients near the end of life. Please join me in welcoming Dr. Robertson-Preidler.
Thank you so much. It's such an honor to be here. Is that good? It's such an honor to be able to be here and share my insights that I've gained through my research, but also through my experience as a clinical ethicist. And as you may or may not know, Olivia and I actually trained together at Baylor College of Medicine. And we began July 2020, which was the height of the pandemic in Houston. And so as you can imagine, these questions and and we were thrown at the bench, to say the least. So this has really prompted me to ask these questions of, well, what can I do as an ethicist? And what can other healthcare professionals do when disputes about when to remove a patient from life-sustaining conditions? This is kind of a new problem. We have more control over life stuff. And with new technologies, it's amazing. And so, hopefully I got the clicker right. My objectives today, let me get my notes because I can't see the screen. Where? Okay. My objectives for today are to clarify some end-of-life terms and concepts. What do we mean when we say non-beneficial treatment? Explore barriers to shared decision-making, and discuss ways to connect with families and bridge disconnects using a relational approach. And I would like to start with a sample ethics consult, something that we might have gotten back in the day at Baylor College of Medicine. It's not COVID related, but it's one that we would typically see. So then, a doctor consults our service and says, "Hey, can I run a case by you?" And I say, "Sure, what's going on?" And this doctor tells me, "Well, we have an 82-year-old patient with multiple complex comorbidities who was admitted to the ICU about 2 weeks ago with acute respiratory distress syndrome due to worsening pneumonia. And since admission, she's had a hemorrhagic stroke, and we have no surgical options for her. She's currently intubated and sedated, and we're trying to wean her from sedation to check her neuro status. But, she continues to be minimally interactive even after we've kind of weaned her from sedation, and she only has spontaneous movements. So I've talked to my colleagues in neuro, and they say that she has a very low chance of significant neurologic recovery or meaningful survival. So we at the team, we're actually really frustrated at this point because we're just not helping this patient anymore, and she has no quality of life. I've been talking to the family, but they just don't get it. They lack health literacy, in denial. They actually think that the patient's squeezing their hand and opening her eyes when they talk to her. They think that she's interacting with them. And we told the family, continued ICU treatment was really non-beneficial at this point. And we suggested comfort care. And when we told them that, they actually got really angry, and they said, "We don't care about her, and we're just giving up on her." And I just don't know what to do anymore, and we need your help. So this is the type of consult we would get, and it turns out it's quite common. Here is a study by Millikan and colleagues showing some of the most common reasons they get ethics consults at this major academic medical center. And the top 3 reasons were conflict over goals, proxy decision-making, and withholding and withdrawing life-sustaining interventions, which of course, these are 3 topics that are going to come up a lot during end-of-life studies. So the questions that we get a lot from clinicians is basically, where do we draw this line? At what point can we say that, life-sustaining treatment should no longer continue? And that's a really hard question to get. So I thought, this is something we really need to explore. And to do that, I think it's really important to first think about, well, what are we talking about when we say non-beneficial treatment? There's obviously distress on the part of the clinicians. What is that distress about? What goals are we trying to achieve? And can these goals be achieved or not? So I wanted to look at 3 major concepts, 3 major terms that are often used, and dig a little deeper. So the first one I wanted to think about is this idea of futile treatment or futility. Since I'm a major nerd, I looked it up in the Oxford English Dictionary to see what they said. And futility, according to the Oxford English Dictionary, signifies a lack of purpose, effectiveness, or success, or something that is useless or vain. A hopeless effort that achieves nothing. And it actually derives from the Latin futilis, meaning leaky, which is supposed to depict a vessel that's leaky, and therefore it's not working. And so I think a way to kind of put this idea of futility is thinking about Sisyphus from Greek mythology. He was a king that was punished after death in Tartarus, which is the equivalent of hell. And he was forced to roll a boulder up a hill, at which point, when he reached the top, it would roll down again. And he'd have to do it over and over and over again. And no matter how many times he did it, he could not achieve the goal of keeping that boulder on the top of that hill. The second term I wanted to look at was non-beneficial treatment. So according to the OED, non-beneficial means not producing advantage or benefit. And typically in healthcare, we were talking about a treatment that cannot achieve a certain benefit, or maybe the harms outweigh those benefits. So going with my Greek mythology theme, this is Tantalus, who was another Greek king that was punished in hell after he died. But this torture was that he was put in a lake with fruit above him. And every time he would reach for the fruit, it would be right out of reach, so he couldn't achieve it. And every time he went to drink the water, it would go below his reach. And so he could never get that benefit that he was seeking. The third term is inappropriate. I'm sure there's a lot of examples of inappropriate treatment from Greek mythology, but I thought instead I would show you this picture of using a hammer or a giant mallet to crack an egg. Because according to the OED, inappropriate means not suitable or proper in the circumstances. So in healthcare, what we mean by this is the treatment is not suitable given the circumstances, the prognosis, the condition, the context. And so these terms together, even though we might use them interchangeably or differently, or some policies might highlight some over others, they bring up similar questions, which I think are very important that we make explicit. What is the goal that we're going for? And I think there's a lot of assumptions here. And when we have different goals and we don't talk about it, then there could be frustration. What counts as a benefit and to whom? And also what counts as a harm and to whom? Can a goal or benefit that we've identified be achieved given the circumstances? And very importantly, how is this information being defined and communicated? And I think it's important to clarify that these questions need to be asked of each treatment because a patient or patient care is never futile or non-beneficial, right? We're talking about specific treatments at specific times. And I think a lot of the fear from families is that fear of abandonment. So Dr. Trevor Bibler, which I understand he was here a couple years ago, we actually created a taxonomy to try to help pinpoint certain important goals that might not be achievable and therefore might be seen as non-beneficial or futile. And I wanted to go through these. So one of the goals might be physiological effect or therapeutic effect. So in this first term, this physiological futility or non-beneficial treatment, is where continued treatment is not reliably expected to produce its expected intended physiological outcome. So an example might be, okay, vent support does not reliably lead to the physiologic effect of proper gas exchange due to serious lung function disease. The second one is imminent demise, where continued treatment is not reliably expected to prevent imminent death. The goal in this case would that we couldn't achieve is prolonged life or survival after until discharge. And an example could be vent support that does provide gas exchange, but the patient will die soon in any case. The next one we wanted to point out was socio-interactive futility or non-beneficial treatment, in which continued treatment is not reliably expected to support or restore a minimal capacity of the patient to interact with the environment. So really the goal we can't achieve in this case is patient awareness or interaction, which can be a very important goal. So for example, vent support provides gas exchange, but it's not expected to lead to neurologic recovery or that in the case that the patient would be awake or be able to interact with their family. And lastly, we identified patient-specific quality of life, futility, or non-beneficial treatment, in which continued treatment is reliably expected to be effective and that it would, provide this therapeutic effect, but it would involve the loss of functional status and decreased quality of life that was not seen as sufficient by that specific patient. Not patients in general, that specific patient. So that's our taxonomy, but a lot of medical societies have actually come up with their own definitions for these terms. And I wanted to kind of overlay that on our taxonomy. So the American Thoracic Society and the Society for Critical Care Medicine define futility in these very specific physiological cases. So it aligns with our idea of physiologic futility or non-beneficial treatment. And they said that the word futile or futility should only be used in those circumstances where a treatment would not achieve a certain therapeutic effect. And then they recommend that in these cases, physicians or clinicians should not provide treatment. And very importantly, they need to provide rationale for not providing that treatment and provide emotional support. That's said in the policy statement. Very, very important. They also said there might be circumstances in which a treatment may accomplish the intended effect, but clinicians believe that there are compelling ethical considerations justifying not. And they specify two circumstances in which that this might qualify. And they called this potentially inappropriate treatment. And this really aligns with these two middle terms because they said in circumstances where the patient will not survive outside the acute care setting, or when the patient has irreversible severe neurological injury, then this might count as potentially inappropriate, even though the treatment would achieve its physiologic effect. And in these cases, they recommend a procedural resolution process. And interestingly, they don't address patient-specific quality of life. And I think that's important to note because I've seen these cases too. I've seen a case, for example, where I got consulted. A wife was beyond devastated because her husband had been resuscitated after cardiac arrest and anoxic brain injury. And she was asking them to withdraw treatment. And actually the doctors consulted me because they're like, the wife just wants to withdraw. She just wants to pull the plug, not even give him a chance. But when I talked to the wife, who was in tears, she said he was in a nursing home before after a stroke. And we had long discussions, and he said, this is no quality of life for me. If anything happens to me, please don't do anything. Let me die naturally. I do not want to lose my functionality more, and I don't want to be dependent on machines. And she felt like she had failed him. And but the physicians, we're thinking about, well, it's medical protocol to wait 5 days to see if there's neurologic recovery. That makes sense from a medical perspective. And they thought anything besides that, was pulling the plug prematurely. So I think it's really important that we think about what's specifically important to patients as well. Okay, so where do we go back to the question of where do we draw the line? According to the American Thoracic Society and the Society for Critical Care Medicine, we draw here at fetal treatment. You do not need to provide treatment that will not produce an intended physiologic effect. It's not expected to. Yeah.
Just stay in the mic.
I'm moving a lot, right? Is this better? Okay, thank you. Y'all are hearing every other word online. I apologize. Yeah, so they draw the line here that you just absolutely do not need to do that. But of course, we do need to provide rationale and emotional support. But they do say that these other reasons might be good reasons to remove treatment, but we're going to not just not provide it, but go through a procedural resolution process. And let me show you what that is. So this is just a summary. This is from Boslett and colleagues from 2015 from the American Thoracic Society. They recommend that you enlist expert consultation. So that could look like a lot of different things. Ethics, palliative care, chaplains, social work. It's great to get a team together to support. Notify the surrogate of the process. Obtain a second opinion of inappropriateness. So this is to ensure the clinical facts are right, but also I think that gives a lot of support to the family as well. They want to know that they've done everything that they can. Have it reviewed by an interdisciplinary committee. Offer surrogates the opportunity to transfer treatment to another hospital. Inform them of the opportunity to pursue appeal. And then at the end of this, implement the resolution process. And this really echoes a lot of non-beneficial treatment policies that you'll see in hospitals. And even is very similar to, we actually have a law in Texas that we call the Texas Advanced Directives Act resolution process, where if we do think that it's not appropriate to continue treatment, we can do this resolution process. That's actually enshrined in law in Texas. We don't use it a lot because hospitals are worried about PR, public relations, losing trust, but it's there to support physicians. So that's what we see a lot. But what is really important to note, that the very first recommendation of the American Thoracic Society in their policy paper on how to respond to requests for inappropriate treatment, their very first recommendation is, quote, for institutions to implement strategies to prevent intractable treatment conflict, including proactive communication and early involvement of expert consultation. And this resolution process is for irretractable conflicts. We want to kind of prevent this if we can. So my recommendation, what I would argue is that, yes, we should draw a line at futility, that, you do not have to provide treatment that's not going to work in a physiological sense. And for these other situations that we, before going through this resolution process, that we do a good job of shared decision, which can be very hard in these cases. So my next bit of research was about figuring out, if we're not drawing a line, what do we do with these other cases? And I think because they are not having to do with whether treatment works per se or not, but rather on values, people are very complicated. And so this process might not be very straightforward, but it has to be person-centered. So what I wanted to do with some colleagues is explore some of the barriers to shared decision-making that we see at the end of life. So to do this, we did a qualitative interview study of physicians at a major medical, academic medical center. You can guess it's one of them in Houston. I won't say which one. And we asked them, and we interviewed physicians of many specialties. And we did this because we were interested as ethicists about what these barriers are. And so, since we are covering all different kinds of specialties, we wanted to hear from different doctors. Okay, so we talked to doctors, we talked to oncologists, neurologists, nephrologists, I'm trying to think who else. Emergency medical doctors, intensivists, surgeons. And we asked them about what they perceive to be the challenges or barriers to shared decision-making at the end of life. And we did these interviews, we evaluated the information, we came up with 7 major themes. And these included physicians' emotional discomfort. This was discomforting even having the conversation, talking about death, giving bad news, letting their patients down. This was very, very emotionally uncomfortable. Organizational barriers such as time constraints, quality metrics, even payment structures. The surgeons pointed that out. Differing perceptions of prognosis and risk. So these were different perceptions from the team versus the family or patient. And so there was this idea of maybe, the family not seeing the prognosis as being as bad as the physicians thought, or they might have a different idea of what risk meant. If a surgeon said, well, we can't do that surgery, it's too risky. And that family would be like, what do you mean it's too risky? They're about to die anyway. What does risk mean? Okay. Then we had the theme of appeals to hope or religion, even when the family did agree with the prognosis. It's very poor, and we know that, but we're holding out for a miracle. And then we had the theme of patient or family mistrust, either of the healthcare system overall or specific clinicians. And then we had social and family dynamics. And by that, I mean that there might have been some kind of conflict or events in the family that preceded this admission that are kind of brought up or even exacerbated because of this challenge, this crisis. And then lastly, patient or family psychological factors. And some of these barriers we thought, well, some are not surprising. We know there's time constraints, obviously, things like that. A lot of times I heard in my experience this thought that the main problem was maybe the family's health literacy or something like that. But what was surprising to us was that most of these barriers were emotional or psychosocial in nature. And these are the things that we're like not dealing with head on, that physicians weren't necessarily trained to do. Like, I work at a medical school now. I can say that is not the main thing they're trained to do. we weren't trained to do it as ethicists, you know, we learned how to do it, right? But we didn't have that training. But that's what's going on here. That's what's preventing some of these decisions from being more effectively made. And I think it's interesting because if you think of the type of conflicts we can have conflicts based on, you know, different access to different information, or maybe insufficient information. Maybe people disagree on what's relevant information, these informational conflicts. Maybe there's value-based conflicts where there's different or incompatible belief systems. And then you have relational conflict, negative emotions, distrust, misconceptions, poor communication. And if you go back to the ethics case that I mentioned, what type of conflict is going on there? There might be informational conflict, right? Because at least from the physician's perspective, they perceived that movements meant something that the team said it didn't. Maybe that's informational conflict. There could be value-based conflict, but we're not really going to be able to look into that until we address the relational conflict, because without addressing that, we don't have communication. We don't have trust. We can't go the next step to uncover these things. So if we go back to the ethics consult, we remember what our physician said, but of course, as an ethicist, the next thing I want to do is talk to the family and get their perspective. And the family says, the doctors say they can't do anything and that mom is really, really sick. We want to share how mom has been responding to us, but they say it's nothing and won't listen and seem frustrated. They say her treatment is non-beneficial, but it's keeping her alive. How can that not be beneficial? It seems like they really don't care about mom and they want to give up. So here you have two very different perspectives of the same case, right? From the team's perspective, the family's angry, in denial, or they lack health literacy, and they are not acting in the best interest of the patient. And from the family's perspective, the doctors seem frustrated. They won't listen. They dismiss what they say. They feel like the physicians have an agenda, and they're not acting in the best interest of the patient. And because of these very different perspectives, we have conflict. But interestingly, there's some themes to this conflict. So both the family and the team are experiencing and also perceiving emotional and psychological distress. There's mistrust. And interestingly, they both think that the other's not acting in the best interest of the patient. What's going on here? And I'd like to explain that through filtering this information, these experiences, these questions through different mental models, which I'll talk a little bit more about in a moment. But I wanted to go through these themes and talk about our research and what we found, what physicians said about these things. The first is the role of emotion. And so one of our themes is physician emotional discomfort. And these are I'm about to show you some quotes. And remember, these are from physicians, okay, describing this discomfort. That's a viscerally difficult conversation to have. Nobody likes to tell someone they're going to die. That's terrible, right? Nobody wants to be the bad person. I think especially junior physicians, residents, other health staff with less experience with end-of-life care in those situations are less comfortable telling patients, look, I don't really think this is going to be helpful to you and what your goals are. And that's when there is conflict. Some people are just very factual and unfortunately sometimes do hide behind what I like to call doc talk, medical terminology. And doctors use euphemisms as defense mechanisms. I'm guilty. We're all guilty of it. This is coming from physicians describing their own discomfort or what they've seen in colleagues. But they also described emotional and psychosocial factors, psychological factors from family. And there were some sub-themes to that as well. So they saw the family as experiencing a lot of pressure in making these decisions. I think it's really stressful to figure out if you're doing the right thing. If it's stressful for me, then I can only imagine how stressful it is for the family, especially if you haven't had those conversations before with a patient before they started having less cognitive abilities. Another major one was denial. A lot of times people are so closed off to those bad outcomes mentally because they're still in that state of denial of hoping that it's all going to be okay. Guilt. Nobody wants to feel guilty. Everybody loves their loved ones and they don't want to be the one that pulled the plug, so to speak. There's tremendous guilt in that, having to make those very, very difficult decisions. Grief. They're so overcome with grief and the thought of losing their loved one that they make decisions that are probably not in the best, not probably what the person would have actually said if they could speak for themselves. And lastly, hope, which this was actually a separate theme, but I was just going to mention it here for the sake of the presentation. Well, people always hold out hope. You can use whatever word you want, a miraculous event, an exceptional occurrence, whatever it happens to be, they'll be the one that beats the odds. And so many physicians, when talking about this, express frustration that this was kind of getting in the way of these effective decision-making processes. But other ones said, well, you know what, that kind of makes sense. It kind of makes sense that they're going through this, right? This really echoes this Elizabeth Kubler-Ross's stages of grief. Denial is the first stage, and they're losing a loved one. So we should actually kind of be expecting this, even though it's a barrier, even though it's frustrating. Maybe it's something we should expect, right? And anger, bargaining, depression before you get to acceptance, especially when there's an acute case, especially when it's not expected. It's really hard to move through these stages of grief in a very short period of time. The next thing I wanted to talk about is the role of trust. So a lot of physicians saw mistrust as a major barrier to shared decision-making. Here's some quotes. You still will often get pushback because people are just generally mistrustful. They just believe that there's some therapy that can get a different outcome, and you just don't want to share it. It's only for someone else. There's this paranoia that because maybe I'm poor or maybe because I'm not whatever, that I'm not getting the best. You're combating suspicion sometimes among ethnic minorities. Understandable suspicion. Atrocity was done to them in human research in the past. This is particularly common among African American families. I just know if you start pushing more, when there's not going that way, you're making the entire situation much worse. Because I think at the end of the day, no one wants to think the doctor is trying to off their family member. If they get that impression at all, I think you lose all sense of credibility and you're not going to make any headway ever. And lastly, I think a lot of my patients think that hospice is the doctor giving up on them. These are some of these perceptions. So they cover both kind of general mistrust and mistrust when specific events occur during decision making. And the last thing I wanted to talk about is the role of different mental models. So how can it be that you have a case in which both the family and the medical team think the other party is not acting in the best interest of the patient? How can we really explain that? And I think one way we could try to understand this is by looking at mental models. So mental models are really frameworks through which we understand the world. So our brain filters all the information, all the experiences that we have through these mental models that were created based on our experiences, our beliefs, our current knowledge, our stereotypes that maybe were built up without even our knowledge, our assumptions and our expectations. And we all have these mental models that we process the world through. And they kind of self-reaffirm themselves. So, so we get, we have experiences and we get new information and it's actually passed through our mental model, filtered out, and then that new filtered information is built up on that mental model and reinforces kind of what we already believed. And this kind of shuts us off sometimes to new perspectives or new ways of doing things, unless we kind of bring awareness to it. And we each individually have these, but we can also see that certain groups or professional groups might develop a shared mental model based on their experiences and based on their training. And I think there might be such a thing. I might get pushback from this. That's okay. That'll be a good discussion of a medical mental model. And this model is really based on the fact that, medical people are trained in the same circumstances and they have to learn certain biological things. And because of that, a lot of times there's this, the mental model is built off of mind-body dualism. So there's a perception that the body is kind of separate from the thoughts and the soul or something like that. Because there's a focus on the biological. There's so much to learn in medical school, right? That we're like really focusing on the body. It's built on clinical experiences, on what are expectations of what good patients should do, and on achieving medical goals. And sometimes there's even conceptualized medical terms as well that maybe the doctor might understand what these terms mean and the context behind them, but patients or family may not. And this kind of mental model kind of informs, and this is not, when I say medical mental model, I'm not talking about physicians. I'm also talking about bioethicists, okay? Because we come up with concepts like informed decision-making. And the idea is, we have these three important elements of informed decision-making: adequate information, understanding, and a voluntary decision that's free from coercion or undue influence. And the idea is if we fulfill these elements, that the patient or the family decision is going to align with our medical recommendations. And if they don't, something went wrong with the process. And it's probably their understanding. So it's like, oh, we didn't communicate that correctly, or they lack health literacy, or that they didn't, something went wrong there with the words. But I wonder if it's more than that. It's not just they didn't hear the information. Maybe they're processing this information through a different mental model, one that's more existential in nature. So they're not looking at the mind versus the body, but just their experience as a human being and their experience of this other person as a human being. And the focus is not on the biological, but on relationships and on this individual and their memories of them and their quirks. And they're focusing on life experiences in general. And they might have various expectations of the healthcare setting. They might have bad experiences. They might have no idea what the expectations are. And lastly, they're focused on personal and relational goals over medical goals. And so I think some things are lost in translation, not in the actual words, but in what we're focusing on. So how can we bridge this gap? That's us bridging the gap. We're about to do it. Let's see if we can do it. Okay. So if we go back to our ethics consult, I don't know what happened in the communication. What kind of went wrong? I'm not sure. But I'm worried because a lot of what we do and what we're taught, and again, I teach in a medical school, so I know this from medical students, is they're taught things like the Spikes protocol, which is excellent at relaying medical information. Okay. Who knows this kind of communication technique? No, okay. Then we'll go through it a little bit. The first, it's kind of a forced acronym, but anyway, I love acronyms. The S is about setting. So we get a comfortable, quiet setting to have our meeting in. And then the P is about perception. And basically in a meeting, you get in this quiet, comfortable, non-threatening setting, and the physician, the first thing they ask the patient is, what do you understand to be happening with your mom? They want to understand their level of medical knowledge so they can build on it. That makes sense. But if in the context of end of life decision making, when you sit down and people are grieving and you're like, what do you understand to be happening right now? My experience has been the family's like, why are you asking me that? Like, don't you know? Is this a test? Like, it's kind of confusing. And the next I is about information where you're supposed to ask, okay, now that you told me what you know or what you think you know, what questions do you have for me? And the family's like, I didn't get any information yet. I don't know. And again, we're having these emotions, right? It's not just normal transfer of medical information. And then, but luckily, then we have knowledge. So then they give the medical update after we kind of know what they know already and what questions they have. And then luckily we have the E, which is emotion. Respect feelings, respond with empathy. And some of my medical students have pointed out that they don't really like, respond with empathy as a check mark item. Because it doesn't say be empathetic. It sounds more performative, right? Reacting. Respond with empathy as the fourth item. And last, summarize. And so what I found is this doesn't really work very well in these specific circumstances. Because as we saw before, the barriers are not, I don't get the medical information as much as it is psychosocial in nature and emotional in nature. And this is kind of reinforcing, well, from the medical point of view, well, this is the important information. This is how we achieve medical goals. But if the family's goals are different, it might not work very well. So my recommendation would be to center around the patient. And we can do this better through a more relational approach to shared decision making. I'm going to point out a couple of different concepts that can help us with this. And so get just a little bit philosophical for a second. So no presentation is complete without mentioning Heidegger. This is Heidegger's idea of authentic solicitude. This idea of dwelling with someone in vulnerable situations. And this requires genuine care and concern for others. Which is not performative, right? It's not showing empathy. It's actually genuinely caring. Sharing in and supporting their existential vulnerabilities. And recognizing the humanity in those we care for. And a second concept I want to mention is that of the ethics of love. This goes beyond the ethics of care. We got somebody new in town. It's the ethics of love. And this was mentioned in Milo and DeCampus Raditsky and a recent book on diverse voices in medical ethics. But I love this concept. It has love as the guiding moral value. And, love is like, well, what does love mean? But love in the sense of agape, this highest form of love for humanity. And this requires attentive presence and respectful accompaniment of patients and families. And it asks us to elicit and appreciate preferences and deeper vulnerabilities and needs, which are often hidden. So you have to pull out these things that maybe even the families don't know are going on. And love does not mean sugarcoating things. That's not love. This highest form of love requires us not to be manipulative or overbearing, but honest and transparent. Because if we're really talking about shared decision making, it should be transparent. We should be a team knowing the information that's going on. And with authentic solicitude and the guidance of ethics of love, we can develop this sense of phronesis from Aristotle of practical wisdom to discern appropriate action. So that goes back to the line that looks like a bird, right? There's no formula. This requires some form of phronesis. And so to do that, I'd like to recommend this new protocol that helps us connect a little bit better with families that I'll call the relational approach to goals of care discussions. And unfortunately, this does not make a very good acronym. And if anyone wants to help me with this, because I spent a few hours and I couldn't even source it. There's too many of them. But I want to go through this and I want to use our case to go through it. So we're going back to the ethics case. So I'll recommend to the physician, let's meet again. Let's have another family meeting. Okay, but this time we're gonna use the relational approach. So the first thing to do, and this would be even before you meet, is the self-reflection. And this is for the clinicians, really. We want to check in on them. We want them to check in with themselves. We might want to have a team huddle. That would be the most effective. What are my emotions and values going into this conversation to validate, and if you can do that as a team, all the better. As the ethicist, it would be amazing to be like, you're saying that you're a little uncomfortable. That makes sense. This is a hard conversation. That makes sense. I'm uncomfortable too. I'm a little nervous about it. What do I think? Why do I think this treatment is non-beneficial? How am I defining goals and benefits in this situation? That might help to identify some of the disconnect, for example, if they have different goals. How is my view on adequate quality of life shaping my clinical judgment? And how might the family's perspectives be different than my own? So this can be done, again, before the meeting. The first thing to do in the meeting, I would recommend, is actually connect with the humanity of the patient and the family. So the emotions don't go at the bottom, they go at the top, because that's what's really important to the family. That is what is bubbling on the surface. And that might look like, we or I really care about your mother. They might need to hear that. And with authentic solicitude, this would be true, that you do very much care for the patient and the family, right? I know this is a really hard time right now, and I'm sorry that your mother and family are going through this. I will be there for you during this difficult time. You will not be abandoned. How are you managing right now? Is there anything we can do to help you manage this difficult time? And some might worry, well, this is going to sidetrack the conversation. But I would argue this is going to sidetrack the conversation anyway, because it's going to come up in different ways. The second thing, and this goes back to being honest and transparent, is to provide context and reason for the meeting. So I saw a lot of times some of the mistrust came from feeling blindsided or cornered. But if we're doing this together and we're creating trust together, I think it's important that we're very transparent. with each other. And so there might be different reasons for meeting, but in the context of our consult, this is what you might want to say, or, one could say, let's say, the reason I asked to talk with you today is to make sure that we're all on the same page and you have all the latest updates. That's going to be part of the meeting, that we answer any questions and understand any concerns you might have. To talk about goals for your mother's care and make sure that we can meet those goals. And if we cannot, to make sure to let you know, because we want you to make sure you have the latest information and that we're making these hard decisions together. To learn more about your mother as a person and make sure that we are honoring her and her wishes and help you make decisions that align with your mother's values. So after, connecting with the emotion, providing context, then we can go to the medical recap and update. And I think it would be important to use lay language. It's really great to have a second person there because what happens is medicalese becomes kind of like a native language, and what you can't tell what's medical jargon or not. So my ex-husband was Austrian, and he would just, when he went home, he would speak German and just throw English words in there. And his mom would be like, "What? You forgot German?" He's like, "What? Did I say something that wasn't German?" Like he couldn't even hear it anymore, right? Because he knew English so well. So that can happen even if that's your second language. So use that lay language. And then if you have an ethicist in the room, we would always do that. Like, you said this, could you explain what that is? To make sure that everybody's on the same page. Focus on milestones over medical metrics. So medical metrics are important, but it's also important that they understand what they mean. So I went through a whole meeting where we talked about the details of care, and a family member said, "Hey, I know this is a stupid question, but is he getting any better?" Like they couldn't tell, right? They're not medically trained necessarily. So I think it's really important. Start from the beginning and go through those milestones and where we are now. So you could say something like, "I'd like to review your mother's illness up to now. And then since we last met," so they're completely up to date. At this point, you can invite questions, I would recommend. After they have this kind of context. I know this is a lot of information, so you can kind of name that. What questions do you have about the condition, diagnosis, prognosis? And then it's always good to have a follow-up question. What other questions do you have? Because these questions kind of pop up, and maybe there's non-medical questions that they might have as well. And maybe some of these questions can't be answered during the visit, but they can be referred. We can talk to the social worker afterward or whatever. Next, and very long and difficult step, I would say, but very, very important, is listing the values, perspectives, and concerns. And this goes back to the ethics of love that calls us to elicit and appreciate preferences and deeper vulnerabilities, often even hidden to the family themselves. And to do that, I would recommend this kind of circular kind of conversation where you're listening, you're confirming what they said, validating what they said, and being curious. So if you talk about, for example, let's look at some examples. You clearly love your mother very much. Tell me about her. So this is the open-ended question you can start with. And something like, as she got sicker, what did she worry about most? Based on what you know about your mother, what do you think would be important for her right now? But you might also want to follow up if they bring up this idea of the squeezing of the hands, to listen, to validate, and to be curious about that. You have brought up that your mother squeezes your hand when you hold her hand. Tell me what that means for you. This is the opportunity. And only when you go through a couple of different cycles do you get to what's really important sometimes, because sometimes we have to talk it out. Sometimes we don't even know it ourselves. I'm hearing that when your mother blinks, it feels like she knows you're with her. I understand how that is very important to you. That's a validation. So sometimes they're going to keep bringing this up until it's validated, it's heard. And if they keep bringing it up, it might be important. So to be curious about that. And to be fair, this does take a lot of time. And if you do have somebody, if you don't have the time as a physician, like this is a lot of things that we did as an ethicist, even maybe separate from the meeting, that we could bring up in the meeting and explore more in the meeting. Then very importantly, and this goes back to these definitions of what do we mean by non-beneficial care or treatment, to identify the family's goals, because you've already identified your own as a team. What are the family's goals? And sometimes it might surprise you. What are your goals for your mother's treatment? What goal could we ideally achieve? So this is what we're going for. And they might say something like, well, ideally, she would be able to go home and live independently again, like she was before. And you can say, okay, I hear that you want her to be able to go home and live independently. If we cannot achieve this ideal goal, what would be an acceptable outcome? Okay, well, I guess it would be acceptable if she could, I'm not sure. I mean, it would be great if she could go home, but I don't know if she'd want to live in a nursing home. She was a very independent woman. Okay. What would not be acceptable outcome for your mother? I guess if she'd have to stay in maybe long-term care for the rest of her life, I don't think she'd want to do that. So to see this spectrum, because we're going to try to get to ideal, but if we can't, we have to know what the other acceptable and non-acceptable options are. Then summarize and confirm. And this is important because we want to make sure that we're all on the same page and they can fill in anything that we didn't cover. So this might be like what your mother's, medical condition is, how you feel that she can sense that you're with her, and this is important for you, what your mother's values are, that, she was religious, she liked to go on retreats, she was very independent. And then did we miss anything? Do you have anything to add or correct about this? Very important. And now we have all the information that we can kind of help facilitate decision-making. We have the medical information, we have the goals, we have the values. And now you can help to facilitate this decision-making. So it is important that we make decisions that benefit and don't harm your mother in the long run, and that aligns with her values. My concern is that given her medical condition and prognosis, she will likely not be able to leave the hospital or live independently. But if we can't meet her goals, the ideal goals, how can we honor her now? What is important to her right now? And then this is where you can give recommendations as well. Given her values and the goals that you think are important for her, I recommend. And this is where, it's possible to recommend comfort care if the other goals are not achievable, the acceptable goals are not achievable. And I think it's really important to describe what that means, because I think there's a lot of fear and misunderstanding about what that means. I had a family once who said they wanted comfort care for their father. And so we called in palliative care and we were talking with them and we're talking about withdrawal. And the family's like, whoa, whoa, whoa. We don't want to withdraw our father from vent support. And we're like, oh, well, you said you wanted comfort measures. We thought that meant what's comfortable for us. Continue treatment. And so I think we have to be careful, right? We need to explain these things. The comfort measures mean I would continue to treat your loved one and communicate with you as before. The goal has just changed to prioritize comfort, because like we saw before, a lot of family members might see it as abandonment, as they don't care that they're giving up, and not as this authentic solicitude, this accompaniment through the pain. We will not abandon you. We're just changing the goals. And repeat, and this doesn't mean repeat it right now, but talk about next steps. This is not the last conversation. And honestly, you might not get to all of this in one conversation. It might be a series of conversations. but talking about, okay, let's plan to meet next week to check on how your mother's progressing towards the goals we discussed. So if you want to, there might be some kind of time limited solution where we're like, well, let's give it one more week to see if she can meet these metrics, if she's doing better neurologically, if it looks like she might be able to get off the vent, something like that. If you have any questions or concerns before then, and I think this is really important, again, we're not abandoning you. This is what you can do. This is who you can contact. And I will see you again, or whoever's coming on service, maybe even name that person. We'll see you again next week. So those are my recommendations for a relational approach to goals of care discussions that can hopefully preempt any kind of dispute that would have to call in some kind of resolution process. Luckily, we do have resolution processes, you know, if they can't be solved, but my experience is that families are grieving. And they just don't want to be doing this alone. And so I think even though we don't necessarily, some of us have the training, like there's a lot of chaplains in here, obviously have the training to help with this. I didn't have the training as an ethicist, but this is the most important work that I did. And I wish I did have that training. But I realized, well, if I just go in and I talk to the family and I listen, that solves so many problems that can create the space that they needed to maybe talk about the medical details that are important for decisions. And so I would say that we shouldn't think of these relational things as like, you know, a back burner issue, but actually as the top issue. Because without addressing those things, we're not going to really make any headway. And that's all I have for you today. Thank you so much for